Welcome to the Centers for Medicare and Medicaid Services Post-Acute Care Provider Training Series. My name is Dave Nolly, and I'm moderating today's training session on MDS 3.0. Today's training will focus on specific items in Section O, Special Treatments, Procedures, and Programs. Before we begin discussing some of the items in this section of the MDS 3.0, I would like to offer an important reminder. While the 2013 MDS 3.0 educational programs provide great information about select sections or items of the MDS 3.0, it is critical to remember that the RAI User's Manual, which is available at the CMS website, must be used routinely by assessors to ensure accuracy in coding the MDS 3.0. Now, Chapter 3 of the RAI User's Manual is where intent, rationale, and step-by-step coding instructions can be found for each section and item in the MDS 3.0. The goal of Chapter 3 is to facilitate the accurate coding of the MDS 3.0 and to provide assessors with the rationale and resources to optimize resident care and outcomes. Before going any further, I would like to introduce our panelists for today. Joining me today are Cheryl Wiseman and Rabia Khan. Hello, ladies, and thank you for joining us this morning.
Thank you very much.
Great to be here.
Today, in addition to discussing the coding instructions for specific Section O items, Cheryl and Rabia will be fielding some questions from the provider community. Cheryl, could you share with our viewers the intent of Section O? In other words, why is this an important part of the MDS 3.0 assessment?
Sure, Dave. I'd be happy to discuss CMS's intent for Section O. According to the MDS 3.0 RAI User's Manual, the items coded in Section O are to identify any special treatments, procedures, and programs that the resident received during the specified time periods. It goes on to say that these interventions can have a profound effect on an individual's health status, self-image, dignity, and quality of life.
I've heard that some of these treatments, procedures, and programs are difficult to understand. Take Item O0100F, Ventilator or Respirator, for example. CMS has received questions that speak to non-invasive versus invasive ventilation. Cheryl, are these really that different?
Yes, they are. There are quite a few facilities that have ventilator units, and several residents on these units may use non-invasive ventilation, NIV. The difference between invasive and non-invasive ventilation is that residents on non-invasive ventilation are not intubated, but are instead supported through the use of a face mask. Some residents need to be on this ventilation 24 hours a day. However, there are some residents who are able to take periodic breaks from this treatment to take medications and to eat meals. Invasive ventilation involves ventilation through an endotracheal tube, and these residents are not able to be taken off this ventilatory support.
So, since there are residents that have different types of ventilation support, can O0100F, ventilator or respirator, be coded for residents using a non-invasive ventilator?
No. In order to code O0100F, ventilator or respirator, the resident must be receiving ventilator support through an electrically or pneumatically powered closed system mechanical ventilator support device that ensures adequate ventilation in the resident who is or who may become unable to support his or her own respiration. Residents receiving closed system ventilation would include those residents receiving ventilation through an endotracheal tube, for example, nasally or orally intubated, or through a tracheostomy. If a resident is receiving non-invasive ventilation and the treatment meets the definition for item O0100G, BiPAP, CPAP, this is the item that should be coded.
Thank you, Cheryl. So there is a place on the MDS to code for non-invasive ventilation. Rabia, can you give us an example that illustrates a ventilator or BiPAP, CPAP coding scenario?
Sure, Dave. Here is an example. Mr. W was admitted 10 days ago after being hospitalized due to acute respiratory distress syndrome, ARDS. He was on a ventilator in the hospital and was extubated 2 days prior to being admitted to the facility. Mr. W was started on post-extubation non-invasive positive pressure ventilation, or NPPV, through the use of a nasal mask. The assessment reference date, ARD, of his admission assessment is today, the 10th day of his stay.
I heard you mention a type of non-invasive ventilation, So would the assessor code this scenario in Section O under BiPAP-CPAP?
Well, partly, Dave. The answer is a little complicated because of how item O0100 is constructed. Let's look at this for a minute. This item has two columns. For column 1, you can see that the assessor will need to check all treatments, procedures, and programs received or performed by the resident prior to admission, entry, or re-entry to the facility, and within the 14-day look-back period. For column 2, the assessor needs to check all treatments, procedures, and programs received or performed by the resident after admission, entry, or re-entry to the facility, and within the 14-day look-back period. Since Mr. W used both the ventilator and the non-invasive ventilation device before admission to the facility, and it was within the 14-day look-back period, both conditions are met. Therefore, both O0100F, ventilator or respirator, and O0100G, BiPAP-CPAP, should be checked in column 1. In column 2, only O0100G, BiPAP-CPAP, should be checked, as only the non-invasive device has been used since admission to the nursing home.
Thank you, Rabia. It does seem like this can be a little tricky to figure out, but that example was very clear. We often receive questions from providers regarding Section O. We have a question from Nebraska, and the provider is wondering how to code respiratory services. I work at a small rural facility, and we tend to get residents who are admitted to our facility due to the chemicals they previously used on many local farms. Mrs. R has been with us for a year now and has a diagnosis of chronic obstructive pulmonary disease, or COPD. She receives respiratory therapy services Sunday through Thursday for 10 minutes each day. Rabia, how would this scenario be coded in Section O?
The assessor would enter 0050 in item O0400D1 because there were 5 days of therapy for 10 minutes per day. 5 times 10 equals 50. The resident received services for 5 days, Sunday through Thursday. CMS wants facilities to count and enter the number of days in item O0400D2 that the therapy was administered for at least 15 minutes a day in the last 7 days. So since there were not any days that respiratory therapy was provided for at least 15 minutes a day in the last 7 days, O0400D2 should be coded with a 0.
I can definitely see why this section requires quite a bit of attention to detail. I think we have time for one more question, and this question comes from Maine. Mrs. J has been in our facility several years now. In her medical record, it shows that she had a CVA less than a year ago, resulting in a left-sided hemiplegia, and that she has a strong desire to participate in her own care. Mrs. J has said that although she cannot dress herself independently, she knows she is capable of participating in the dressing activity and wants to pursue her overall goal of being able to complete as many ADLs as she can, as independently as possible. After talking with Mrs. J and working with the Restorative Nursing Program staff, an individualized care plan has been developed that should help Mrs. J reach her goals. Right now, our staff is concentrating on assisting Mrs. J to maintain the ability to put on and take off her blouse with little or no physical assistance from the staff. To this end, all of her blouses have been adapted for front closure with a hook and loop type fastener. The restorative nursing assistants have been instructed in how to verbally guide Mrs. J as she puts on and takes off her blouse to enhance her efficiency and maintain her level of function. It took approximately 20 minutes per day for Mrs. J to complete this task on each day of the week. This information is documented by the staff providing this intervention, while our nursing staff oversees the program to ensure that things are going in the right direction. How is item O0500, Restorative Nursing Programs, coded in this scenario? Cheryl?
There's a lot of information in this scenario, and it is very helpful in determining what needs to be coded in item O0500, Restorative Nursing Programs. There are several criteria that must be met in order to code for restorative nursing programs. There have to be measurable objectives, and interventions must be documented in the care plan and in the medical record. There has to be evidence of periodic evaluation by a licensed nurse in the resident's medical record. When not contraindicated by State Practice Act provisions, a progress note written by the restorative aide and countersigned by a licensed nurse is sufficient to document the restorative nursing program once the purpose and objectives of treatment have been established. Nursing assistants aides must be trained in the techniques that promote resident involvement in the activity. A registered nurse or a licensed practical vocational nurse must supervise the activities in a restorative nursing program. Sometimes, under licensed nurse supervision, other staff and volunteers will be assigned to work with specific residents. An important thing to remember is that restorative nursing does not require a physician's order. Nursing homes may elect to have licensed rehabilitation professionals perform repetitive exercises and other maintenance treatments, or to supervise aides performing these maintenance services. In these situations, the services may not be coded as therapy in Item O0100 therapies because the specific interventions are considered restorative nursing services. The therapist's time actually providing the maintenance service can be included when counting restorative nursing minutes. Although therapists may participate, members of the nursing staff are still responsible for overall coordination and supervision of restorative nursing programs. Also, restorative nursing does not include groups with more than 4 residents per supervising helper or caregiver. From the scenario presented, it seems as though these criteria are being met. When you look at the number of days and the minutes of training and skill practice that were provided and documented, it should lead the assessor to code O0500G, dressing and/or grooming, with a 7, because this was the number of calendar days that restorative nursing training and skill practice for dressing was provided, for a total of at least 15 minutes each day for the last 7 days.
Thank you, Cheryl. We have covered a lot of information in today's training and answered some great questions from the provider community. I would like to thank our presenters, Cheryl and Rabia, for joining us today, and you for your time and attention. We hope that you found this training on Section O to be helpful. Ensuring MDS 3.0 accuracy is critical to ensuring accurate care plans, quality measures, and much more. If you have additional questions regarding Section O, please refer to the MDS 3.0 RAI User's Manual. If you still have a question after viewing this training and referring to the RAI User's Manual, please feel free to contact your state RAI coordinator. There's a list of state RAI coordinators in Appendix B of the MDS 3.0 RAI User's Manual. Remember, the work that you do is important to ensure that the best possible care and quality of life is afforded to the residents of America's nursing homes. To all of you taking part in this educational activity, I again thank you for your time and attention on behalf of myself, Cheryl, Rabia, and CMS.